Okay, good afternoon and good evening, everyone. My name is Seung-Keun Lee, working for the Seoul National University, Department of Periodontology. Today, I'm greatly honored to play important part as a moderator for the Dr. Lee's clinical cases. Dr. Lee's have updated so many clinical cases. Today's topic is about immediate implant placement and ridge preservation. Let me briefly introduce his case first. This is case preview. Immediate implant placement and alveolar ridge preservation. Patient information, age is 51 years, male patient, presented to the clinic with the chief complaint with the number 15, crown was broken, leaving only the root, and the number 37, my teeth are painful and sensitive. And as a past dental history, he doesn't have any specific dental history, and as a present illness, number 15, crown fracture, and number 37, root caries with the apical periodontitis. This is a patient clinical photo and the panoramic radiograph. Root remnant removal with, this is today's surgery plan. Root remnant removal with the periodontal instrument for the minimizing damage on alveolar bone, and implant placement, which is going to be used, the superline 4mm diameter and 10mm length will be used, and healing abutment connection after exo, as long as the primary stability is okay. The gap defect filling with the bone substitute, probably the synthetic bone substitute, is osteon 3 collagen, collagenated bone graft material. So, this carefully number 15, second premolar on right, maxillary second premolar on right hand side, and the panoramic radiograph. So crown was fractured, and then the surgeon decided to extract the tooth. For immediate placement of implant, as all we know, we have to get the primary stability, which means we have to have a proper bone quality and quantity after tooth extraction. So I think the root length is pretty enough. Therefore, I don't think there's any problem of getting the primary stability after immediate placement. So measured through the cone beam CT, and we had the proper length beyond the apex of the root. There are pretty much of the bone. If there is not enough primary stability, we could use some bone beyond the apex of the root. Therefore, which means we don't have any problem getting the primary stability. The width of the bone is 8.62 millimeter. Considering 2mm safe zone, buccal side and palatal side, I don't think it doesn't have any problem with placing diameter 4mm diameter implant there. So this is the similar cases Dr. Lee already practiced. So because of root crown fracture, second premolar had to be extracted, and after tooth extraction, the immediately implant was placed. Probably diameters 4.5 or 4.0. So leaving the gap defect on the palatal and buccal side. Usually the anterior tooth implant, immediate placement in the anterior tooth area, we are leaving only the gap defect on the buccal side. However, in the premolar area, usually we placing implant in the middle of the socket. Therefore, there will be gap defect buccal side and the palatal side. After immediate placement of implant, bone graft was performed and suture was performed, and after several weeks, and provisional restoration was delivered, and the final restoration was also delivered. So before making the final prosthesis, Dr. Lee probably had the soft tissue molding with customized impression copying, and the final crown was made. And customized abutment was used for the final restoration. This is final prosthesis. I think because some reason he had this cement retained type of the restoration, because he placed the implant pretty well in good position. I think the screw retained restoration was possible, but for some reason the cement retained type of restoration was delivered and maintained. About number 37, second molar, lower second molar, the ridge preservation will be performed. Ridge preservation usually performed for the compensating ridge resorption with the bone substitute. Same synthetic bone substitute, osteon 3 this is not collagenated bone graft, just particulated bone graft. Osteon 3 this is collagenated bone graft. Osteon 3 collagen will be delivered, and collagen matrix will be used. The reason why nowadays we are using the collagenated bone graft and the collagen matrix for the ridge preservation procedure, I'm going to explain later after the live surgery. One of the most appropriate suture technique will be used. I think his favorite suture is hidden X suture. I think matrix suture and the X figure suture is very good for the ridge preservation technique, because one of the reasons for doing this kind of suture is securing the bone graft and matrix in position, which means we have to prevent particle dissipation, or the matrix has to be in position for the initial healing period. That's why people like the matrix suture or X figure suture. And also hidden X suture, I'm going to show later about the literature, a paper about that, and there's some advantage of this suture. So this, I think this is this lesion number 37. I think they started with the dental caries and it became bigger. And also, I think it has some problem with distal area. So I think the perio and the reason. This tooth has the apical periodontitis, and also I think that if you proving the distal area number 37, there will be some deep pocket up to the apex. So therefore, I think this tooth has to be extracted because perio and the reason. Yeah, if you see in the cone-beam CT, there is some there's widening of loss of periodontal ligament and some lesion in the buccal and the lingual side also. So that's why the surgeon decided to extract the tooth. I'm going to show the similar case. After the extraction of the second molar, apply the bone graft and the matrix and the suture. This is the not immediate placement protocol, probably delayed or waiting about 3 months of the initial healing after bone graft and the placing implant later. So this is kind of this is not the immediate implant placement of implant in the healed ridge after ridge preservation. Yeah. I think usually in the second molar area, the reason why we have to extract the tooth is peri-origin. In that case, there is a lot of inflammation tissue. Even though we are trying our best to remove all the granulation tissue, I think it is not enough. So it will be better waiting some healing period after bone graft and then placing implant later. So this is usually the second molar area. I'm doing this kind of procedure a lot in my office, in my clinic. So let me see. Implant. So even though rigid preservation was performed after tooth extraction, during the implant placement procedure, another bone graft has to be done. So and waited and the second surgery. Yeah, this is rigid preservation and the delayed implant placement protocol. And final restoration using the customized impression, customized abutment, and screw type of restoration, screw retain type of restoration. So final restoration, this was the similar case. Okay, these were the two similar cases. So as I mentioned, the immediate implant placement and upper premolar area and other rigid preservation on the lower second molar area. Let's go to the clinic. Yes. As I mentioned, the second molar has to be extracted because of the perioendo reason. It started with the root caries. However, there's some deep pocket on distal area. If you see after tooth extraction, usually there will be some, dental calculus deposit on distal area. Usually we are using the cow horn type of the extraction forceps. So you see there is some distal area, there is some subgingival calculus there. When you are extract the second molar, we have to be very careful to minimize the fracture of the tooth. For the better result after rigid preservation, we have to minimize the damage of the extraction socket. Therefore, we have to gently hold the tooth with the forceps and move it buccal and lingual side to minimize the fracture of the root. If the tooth fracture, I think the damage of extraction socket is inevitable. So I think minimizing the damage of the extraction socket, I think we have to gently extract the tooth without any fracture of the root. And also another, he's using the curved surgical curette. Is good for the adaptation to the buccal side and lingual side. I should have mentioned about the anatomic structure. Usually after second molar extraction, when the distance from the apex, root to apex to the inferior alveolar nerve, if it is close, we should be very careful not to damage the inferior alveolar nerve. But in this case, there was pretty much of the bone between the apex and the mandibular canal, mandibular nerve. Therefore, we have to do the thorough removal of the granulation tissue after tooth extraction. This procedure, he's using mosquito hemostat for using the granulation tissue. We can use sometimes blade, we can use sometimes hemostat, we can use sometimes we can use a rotary instrument to remove the granulation tissue, and also surgical curette. Dr. Lee used the curved extraction, surgical curette first, and for the distal, approaching the distal area, he's using straight surgical curette and removing the granular tissue thoroughly. The reason why the thorough removal of granulation tissue is very important is that if there is some remnant of the granulation tissue before applying the bone graft, let's say there's a lot of inflammation, and the granulation tissue was left, and applied the bone graft. According to the literature, there will be, even though we are applying the bone graft on the extraction socket. Because of some inflammation condition, bone graft will be resolved very fast. Therefore, we cannot get the successful clinical outcome. So this is a procedure he's doing. I think thorough removal of the granulation tissue is very important procedure. As I mentioned, in case, let's say the root tip, apex, and mandibular canal is very close, let's say. So then we cannot remove the granulation tissue in the apex area. In that case, for me, I remove the granulation tissue, buccal, distal, and lingual. But because we cannot remove the granulation tissue in the apex area, instead of grafting, bone grafting, I'm waiting, applying the collagen plug and wait some time of healing. Then I tried some bone graft procedure after probably 3 weeks. 3 weeks means it's pretty good time, enough time for the removing the inflammation subside. Therefore, after 3 weeks, after tooth extraction, we consider the bone graft material for kind of bone rich preservation or rich augmentation, whatever. For this case, because he could remove all of the granulation tissue, I don't think he has any problem applying the bone graft rich preservation procedure. It takes a lot of time. You know, after time for the extracting tooth, it took him about 2 minutes, 1 or 2 minutes, but to see how many minutes he's spending the removal of the granulation tissue. I think he's doing because it's a really important procedure for successful treatment outcome, especially in case of a lot of inflammation condition. As I mentioned, curved surgical curette is good for applying to the buccal and lingual side. And another thing, when you are removing the granulation tissue on the lingual side, you have one important anatomic structure exists there, the lingual lobe. Just be careful not to go further, not too much distal area. But the lingual lobe is going through the distal area and go through the distal area, distal area, second molar. Therefore, the lingual side, you have to be very careful not to damage the lingual lobe. I think one more thing we have to be careful is we have to minimize the damage of the buccal soft tissue, because if there is some damage, a lot of damage on the buccal tissue, buccal soft tissue, vestibule will be shallow, end up with the shallow vestibule. As all we know, shallow vestibule has a lot of problem, food packing and some inflammation after the implant placement. So when we see through the long-term maintenance, there will be some problem. So if there is a lot of damage on the buccal tissue, there will be more chance of the shallow vestibule. Shallow vestibule will end up with some problem around the implant soft tissue. I think almost done. Yeah. You see, there's not any, granulation tissue inside the extraction socket. He's applying now the collagenated bone graft, Osteon collagen 3, synthetic bone substitute, HA and TCP combination. And using the bone packer instrument, one side has something like the micro mirror, and the other side has some shape like bird's beak. So first apply the something like the spoon shaped instrument and applying the bone graft. Another thing I've heard, Dr. Lee's preference for the soaking the collagenated bone graft. Usually, if you apply the collagenated bone graft extraction socket, there's 3 ways we can soak in the solution. So sometimes we can use a saline, and sometimes we can use the blood. And so I think his preference was using the saline and metronidazole and saline solution to minimize the infection on that area, because this extraction socket has a kind of damaged extraction socket, or some kind of there is some chance of the infection. Therefore, she chose one way of the soaking the bone graft material with that material. And condensing is really important. We have to condense with the plugger on the end tip of the or whatever, and parental probe on dental mirror. And applying the collagen matrix. For the extraction socket, for the rich preservation technique, proper barrier membrane or collagen matrix could be applied for that purpose. Usually it has been used, the membrane has been used popular, but nowadays there's some paper applying the collagen matrix. My preference is applying the collagen matrix. It's very good for manipulation, and also the reason why we are applying the collagen matrix on the top of the bone graft is enhancing the soft tissue healing, and another reason is minimizing the particle dissipation. So therefore, collagen matrix pretty better work than the collagen membrane. Therefore, my preference is also using the collagen matrix. He used the collagen graft, which was made in the genus Dentium, and he's using the hidden X suture, starting with the buccal side. And X figure should be inside of the socket, and some matrix figure should be out of the extraction socket. You will see. Well, I'm going to show the schematic drawing later about it. As you see, the old X figure is inside of the extraction socket, and some kind of matrix figure is out of the extraction socket. That's a hidden X figure suture technique. It's good for the rich preservation technique. You can choose whatever you want for the suture technique. The main purpose of this suture technique is for the maintaining the bone graft material matrix in position, securing the bone graft and matrix in position. Therefore, we can enhance the healing of the insertion socket, and we can expect more better quality of the bone after healing period. Okay, I think it's beautifully performed. As a precaution for after extraction, I always tell the patient not to goggle, don't use too much of the mouthwash on that area. Sometimes, as I mentioned, this is very important. Bone graft material method should be in position for the early healing period, probably 2 weeks or 3 weeks. If the patient goggle the mouthwash on water, whatever, too strong, I think the particle will be dissipated to the intraorally, end up with the unwanted treatment outcome. Okay, he is now start to extract the tooth on the number 15. Sectioning tooth. The reason why we are sectioning the tooth for the extraction to minimize the damage on which could be made during the extraction procedure. Sometimes we can section the tooth. We can section mesial-distal direction or sometimes buccal-lingual direction. And applying some kind of removing the parental ligament it will make it more, supplying the elevator. I think that's specially designed device, instrument. I'm not sure what it is. So I think it's very good for luxation. I have to ask him someday. Well, I think could be easily removed. I'm sorry, I don't know. I have never seen that instrument. I was thinking that he's applying the elevator, which I'm using in my clinic. He is using different instrument. I have to ask him. I'm going to let you all guys know. I'm going to ask him, and I will let you know. I think this instrument is pretty good for the removing the root remnant, minimize the damage of adjacent tissue. Instrument is not straight, as you always see. There's this curved instrument, and it's very efficient for the applying the force between the tooth and the parental ligament. I think that for good adaptation, the instrument was curved, shank, sharp. End of the tip, it looks like, very sharp end of the tip. It will be good for adaptation of the instrument between the parental ligament and tooth. It takes time, you know. He spent a lot of time for removing the granulation tissue, in previous case, because it is very important. I think most important procedure. He spent a lot of time for this immediate implant placement case. I think there is most important. One of the most important thing is minimizing the, trauma, minimizing the damage on the adjacent tissue, which means we should not break the alveolar bone. We should not make any damage on the parental ligament, if possible. And using forceps, he is removing the remnant of the root. Good. Usually in this case, as all we saw, the palatal bone probably intact in this case with the root remnant. There was not any, parental disease. This tooth is extracted because of the root fracture, the crown fracture. Therefore, the root part, the alveolar bone and perial condition is really good. Therefore, we don't have to worry about the palatal side. However, the buccal side, we don't know exactly because usually there is thin bone plate is left, and during the extraction procedure, the buccal plate could be damaged. So we have to evaluate carefully whether the buccal bone is intact or not. If the buccal bone is intact too much, we have to apply some, the collagen membrane, anyway, the barrier membrane on buccal side to compensate the loss of the buccal part. And also, thorough removal of the granulation tissue is being performed. That is very important. I think the buccal bone is not damaged too much, so it probably could be a good indication for the immediate implant placement. Instead of opening the flap, he's applying the interproximal knife to the buccal side. I've heard he's using this instrument to make sure whether the buccal bone is intact, to make sure to evaluate the buccal bone condition instead of opening the full thickness flap. He made sure buccal bone is not too damaged, not damaged too much, was not damaged too much. The granulation tissue remover, and probably he will place the implant. We will start the bony site preparation for the implant placement. As we saw in previous similar cases, usually position of the buccal position of the immediate implant placement for the second premolar area in the middle of the extractions. Okay, usually anterior tooth area, we are placing implant palatally and leaving some gap defect on buccal side. But the premolar area, usually we placing implant in the middle. It's good for the, for the good, better long-term result, and also using the stopper for the depth control. Nowadays, the dentists don't like the place in the long implant, which means when I was trained in university, when I was a resident, we played the 12, 14, 15 millimeter of the implant length. Nowadays, we are not using that kind of implant. Reason why we use the long implant length, because we can get better, primary stability from the bone located in the apex of the root. He's measuring the proper depth. He didn't open the flap, but he measured where the buccal bone is located. The crestal part of the buccal bone is located. It is very important because we have to decide where the platform of the implant it would be located depth-wise. So he's controlling his process. In his imagination, he has some imaginary line of the buccal crestal bone height. Therefore, the placing implant at that level or a little bit 1 millimeter or 0.5 millimeter deeper than the imaginary line, which means the buccal bone crest. It is more important when you are doing the immediate implant placement in the anterior tooth area. Because if the implant is placed too shallow, as all we know, there is some metal exposure, you end up with the compromised aesthetic result. I think he's preparing the implant. The spline implant is being placed. And he's making sure whether the primary stability is enough for the implant or not. This is immediate implant placement and with bone graft on the gap defect, which is left after placing implant, buccal and palatal side. open the flap, open the mouth, and checking implant position is pretty good or not. Because we get the primary stability of the implant, we could connect the healing abutment. If the primary stability is not pretty good, we have to consider connecting the cover screw and submerging implant, waiting some time for the healing period. Probably he will connect the healing abutment. Yes, he got the pretty good initial stability and connecting healing abutment. Making sure some part of the healing abutment is exposed above the gingival line. And he's also using the collagenated bone graft material. I've heard without pretty much of the inflammation condition, it's kind of some intact extraction socket. I've heard I don't think he's using the antibiotics soaking. Probably, I think the saline soaking is pretty enough for this case. But sometimes we can use also the soaking for the bone graft material with the antibiotics and the saline solution mixture. The applying bone packer. As I showed you, one side of the bone packer looks like this, bird and the bird beak, and the other side looks like the small mirror, micro mirror. Because this gap is probably 1 or 2 millimeter, I don't think we need collagen matrix for this case. Sometimes if there is some major damage on the buccal plate, we apply the collagen matrix or collagen membrane buccal side first, then we apply the bone graft material. But I don't think this is not the case. The buccal bone was intact, and just only applying the bone graft material. Collagenated bone graft was soaked, probably mixture of antibiotics and saline. Good. And I think this instrument looks very convenient. I would like to buy one for my clinic. And also the extraction, the tooth elevator. He used the sharp end of tip. I think it's pretty good for the extraction without damage from surrounding tissue. This is the other side of the bone packer. Applying the bone graft into the gaptic bag. We don't need the remnant, that's why he's removing the remnant above the bone crest. No, he's now suture. I'm not sure whether he's using the hidden X suture or not, but start with the vocal side. Yeah, sometimes it's difficult to make the suture on the vocal side, palatal side. It takes time. Same thing happened to me. This is not X figure suture. I think this is the matrix suture. Because the implant was placed in the middle, we don't need the X figure suture. But the flap on vocal side and the palatal side should be closed after the suture. Close each other, I mean. Yeah, we can also remove the remnant. It's a good way to remove the remnant of the bone graft material with the saline irrigation. I think it's done for today. Extract the tooth with minimal trauma and place the implant with the proper primary stability and bone graft on the buccal and the palatal gap defect, and made suture with the matrix suture. Keep both sides of the flap maintaining close each other. I've heard he's using he applied the dexamethasone, which is corticosteroid, one kind of corticosteroid, to enhance the healing and minimize the inflammation on surgery area. That's why he injected the corticosteroid on that area. Okay, let's wait. We're gonna have some Q&A time, and during his finishing the surgery and taking radiograph, panoramic radiograph, and we'll start in 10 minutes. the panoramic radiograph is ready after surgery. Yeah, I think it's beautifully performed. If you see the number 15, second premolar first, he measured exactly what he had to do. The apex didn't go beyond the, the sinus area, and the implant was placed a little bit deeper than the interproximal bone area, and I think he get pretty well primary stability, and axis location I think pretty perfect. And 37, the second molar area, I think the bone graft packed pretty well, and he built up a little bit over built up. I don't think it's any problem, and didn't have any particle. Is bone graft material is being placed and secured in position pretty well. I think it's beautifully performed. Yeah. Okay, so let me briefly explain about the rigid preservation technique. It started with early 2000 with this paper, which was made in the Dr. Araujo. He found in the animal study, without after tooth extraction, the buccal side resolved pretty fast because of the buccal bony plate is composed of the lamella bone, and during the extraction procedure, buccal side could be easily damaged. Therefore, other than the lingual side, L means lingual, B means buccal, there is pretty much of the bone loss on the buccal side. That's why we have to consider the rigid preservation after tooth extraction, especially on the anterior tooth area. The recommended procedure, clinical procedure for the rigid preservation technique, the best result, best clinical outcome in the animal study was shown with the technique with the bone graft material packet, and whatever material, I think the bovine material and the synthetic material is pretty good. Not the autogenous bone graft on the rigid preservation technique, because the bone graft has to be resolved a little bit slowly. Therefore, since xenograft or the synthetic bone graft is pretty well, and applying the bone graft and cover with the fringe graft from the palate is recommended procedure and show the best result compared with other technique. They compared the other technique, which means opening the buccal flap and applying the bone graft on the buccal side out of the extraction socket, and extend with some kind of periatom, applying the expand the rich dimension and weight, and they found out the two other techniques. I think the X figure, it was not pretty good, and the only best result was from the clinical technique, the bone graft material and covered with fringe graft. But for the rigid preservation technique, it's very difficult to get another donor site from the palate. It's patient don't like it, and it takes more clinical chair time. Therefore, instead of the fringe graft soft tissue, we are considering the barrier membrane or the collagen matrix. And the recently published paper in the which 2023, I think 2023 March, April. If you see carefully on the bottom of the slide, the International Journal of Oral Maxillofacial Implant. In this paper, they compared the result with the same thing, the applied bone graft material. For some case, we apply the fringe graft, we apply the collagen matrix, and we apply the collagen membrane on the top of the bone graft material, and they found out there's no difference in the volumetric maintenance and tissue formation. Therefore, for convenience, probably we can apply the collagen matrix and the collagen membrane. The reason why, my preference is collagen matrix. Is collagen matrix is better manipulation, and there's in the literature, collagen matrix could enhance the soft tissue healing And so soft tissue healing is really important because we have to cover the extraction socket as fast as possible to minimize the particle dissipation, and it will make the better treatment outcome. Therefore, my preference is collagen matrix. And they found out no difference. Then, yeah, we can choose whatever we want: collagen matrix, collagen membrane, and fringe bar graft. But nobody wants the donor site, additional donor site. Therefore, we have to choose collagen matrix or collagen membrane. I think in my clinical experience, collagen matrix is better than the collagen membrane. So I conducted one animal study compared for the extraction socket. This is kind of a damaged extraction socket, and we applied the rich preservation technique. And one side collagen matrix, and the other side collagen membrane. And we found out that the left-hand side is membrane, right-hand side is matrix. If you see the soft tissue area, there is some thicker, well-healed soft tissue. We can find the group 2, which means group we apply the collagen matrix. So my preference is collagen matrix based on this kind of study. This is the result. If it's the rectangular, it's collagen matrix. It's not really has difference, but has the higher, better result than the collagen membrane. So nothing to lose. Collagen matrix good for the adaptation, good for manipulation, and good for the soft tissue healing. Therefore, my preference is always the collagen matrix for rigid preservation technique. This is the clinical procedure I'm doing in my clinic, applying the collagenated bone graft and applying sometimes 2 layers of collagen matrix, and sometimes the second layer, when there is no buccal bone, we have to compensate the missing buccal wall. Then we apply the collagen matrix on the buccal side to compensate the missing buccal bone. So apply collagen matrix first and the bone graft packing. And in case of severe bony case on the bottom, in that case we have to get the primary closure, because we are applying a lot of bone graft material after tooth extraction. In that case, instead of doing the rigid preservation technique, I choose the rigid augmentation, granulation tissue removal, and applying a lot of bone graft material, and flap manipulation, making the advancement of flap and making the primary stability to minimize the loss of the bone particle during the procedure. So collagen matrix is very good material for the rigid preservation. This is the first case, applying bone graft and the collagen matrix when the buccal bone is intact. And when there is a buccal bone missing, we are applying the collagen matrix to compensate the missing buccal wall and apply the bone graft material. This is a hidden X suture. X figure, as I mentioned, is inside of the extraction socket, and the matrix suture is out of the extraction socket. It's good for the equal distribution of the tension. And in this case, we don't apply any force on the extraction socket. So some other suture, there's no force on the buccal and lingual side. Therefore, we can maintain the control of the extraction, soft tissue of the extraction socket. That's the one advantage of this hidden X suture. X suture looks like that, but X figure is out of the extraction socket. It will make it, the buccal and the lingual side, make it the distance, and buccal and the lingual will be closer after this suture because there is some force applying the buccal and lingual direction. You know what I mean? So hidden X suture, there's no force applying the arrow, that kind of force. It end up with decrease the dimension of buccal lingual widths. Therefore, go back to the hidden X suture. There's no force applying the buccal and lingual direction with the hidden X suture. But the X suture, as you see, there's force with the outside of the extraction socket. There's X figure, there will make some force. So decrease the dimension of the buccal lingual direction. Sometimes I could use the crisscross suture, but it also have some buccal direction, force, decreasing the dimension. So they measured, there is a mucogingival junction line. They compared with hidden X suture. They found out there is some advantage in the keratinoid tissue preservation and maintaining the dimension of the buccal direction. So in this paper, the hidden X suture has this kind of advantage. But this is the only paper that explain the hidden X suture. Instead of this advantage for the convenience, sometimes we can choose the X suture or crisscross suture to minimize the loss of the bone graft particle. But for maintaining the buccal dimension, I think the hidden X suture has some advantage. That's the conclusion. So as a Q&A, what are the key patient factors to consider when performing the immediate implant placement? I think, as I mentioned, there has to be, pretty much of the bone, and for getting the proper initial stability and the bone quality also. And there should not be not much of the damage on the buccal bone. If there's too much of the damage on the buccal plate, then we have to consider rigid preservation and placing implant later, because we don't know how much of the bone loss there would be after healing, after the tooth extraction. Therefore, let's say we place the implant some location the vertical wise. If there is some more bone loss during the healing, some part of the implant will be exposed. Therefore, end up with the compromised cell result. Therefore, if there's pretty much of the bone loss on the buccal side, I think it would be better to consider the delayed implant protocol. But the case Dr. Lee performed, it has the intact buccal bone and the bone quality and pretty much of the bone beyond the apex. So then we can get the primary stability. I think the key factor is the primary stability. As long as we can get the primary stability, we can consider immediate implant placement. Yeah, that's the answer to the question. I think this is all about it. Thank you for your attention. Yeah, thank you for watching. Thank you for your attention. Yeah.